depression and brain network in head injury. So I'll start with brain network in head injury. Yeah? So the topic is head injury, not brain injury. Yeah? But never mind, because why we use the word head injury? Because your head consists of your eyes, your ears, you have skin over your skull. The head is also part of your nose. You use your nose to smell. The tongue is also part of your head. You use the tongue to taste, to drink, to swallow. Okay. So whatever happened to your head, not only your head, but also because your brain is there, anything that happens to your tongue, to your ear, so your tasting apparatus, your hearing apparatus, your smelling apparatus, and sometimes your sensation, whether you like it or not, we don't only feel sense using our fingers, our legs, but even our face is involved in a lot of the sensation associated with we call it fine sensation, the wind that touched on your face, etc., etc. When you have a toothache, that also involves your head. So there are many. The head has got a network of nerves. You have the peripheral nerves, you have the cranial nerves, you have the brain, you have the brain stem, you have the cerebellum, and all these cranial nerves and peripheral nerves are interrelated. Okay, you have your hair on your head, so the hair also provides a lot of sensation. So when you're thinking about head injury, so head injury is any injury to the head. That means the head consists of your brain stem, cerebellum, right? So again, eye, ears, tongue, mouth, your throat. Okay, a part of your throat is part of the head. So when you have an injury, the injury can be due to a road traffic accident, can be due to a fall, can be due to many things. It can be a mild injury just playing football, rugby, netball. You may be maybe ice skating, and while you are ice skating or roller skating or board skating, you fall and injure your head. Okay, and in your head you have the brain. So directly or indirectly, your brain will be involved. And if the cranial nerves, there are 12 cranial nerves that connect the eyeballs, nose, tongue, throat, muscles to your brain and brain stem. So even any injury to your eyeballs will also involve your brain. So the brain will bear the brunt of most. That's why it's called brain network in head injury. Or if you want to make it more plural, or you can make it head injuries, because there are more than one type of injuries. So you may have the classic road traffic accident. You may have just a simple fall. Okay, you may have injury just playing football in Malaysia, heading the ball, sepak takraw, which is a common ball sports using the rattan ball. That is also very hard, and that can cause head injury, and indirectly or directly cause brain injury. So when injury occurs, secondary to trauma, because here we're talking about trauma, and in Malaysia, trauma is an epidemic. The brain trauma or head injuries are epidemic. In fact, they are the highest cause of morbidity and even mortality after strokes and brain tumors and any other diseases. So knowing if you ever venture out into the world of wellness or illness, you will find out that the knowledge of brain injury is very important, because for you to manage the client or the patient, the areas where the brain is injured is necessary for you to recognize before you can treat. So because the outer layer of the brain is all gray matter, so the gray matter will be injured first. I think nobody can deny that. But you know that neurons are attached to axons. Many axons become vesicles or white matter. So whether you like it or not, gray matter injury will also lead to white matter injury, and pure white matter injury, which is quite rare, will also lead to injury of the gray matter because of the biology. This is not like you're taking a piece of wood, you snap the piece of the branch into two, it's a clean cut, that's it. You can take the two pieces of the branch, stick it back into the ground, water the branch, and maybe a whole new tree or plant will grow out from those branches. In the brain, it's not that simple, and that's why the neurobiology of traumatic brain injury should be recognized. So when the neuron is destroyed, the axon will die after the neuron dies, or even together with the neuron, depending what kind of injury. And then it will destroy, most importantly, the white matter tracts. And the white matter tracts, you're going to have an exercise from the 1st of December, where we will introduce you to white matter tracts that connect gray matters. And they are white matter tracts. They are found in all lobes of the brain, and they are connected to their respective gray matter area. And some of them cross from right to left, front to back, back to front, up to down, down to up. Some of them are short distance, like for example, the network between in the temporal lobe, for example, is like driving from Kuala Lumpur to Shah Alam, very short, and that road from Kuala Lumpur to Shah Alam, even though it's a short road, may contain lots of important gray matter and white matter for memory, for example. Or you may have the road for vision. So from your eyeball, it goes into your brain, so you will use your frontal lobe, your temporal lobe, and parietal lobe, and then the track goes back to the occipital lobe. So there is a long pathway. This is like driving from Johor Bahru to Perlis, a long drive. And then you can have injury or to the tracks along this pathway, or the road from Johor Bahru to Perlis. There may be potholes, there may be landslides, etc., etc. So the distance of the track in the brain will determine also what kind of injury the client or the patient will have. So, and in the brain itself, the brain is in a swimming pool, which is cerebrospinal fluid, and then it is in a container, the skull. So the container, the skull, like if you buy a Tupperware and you put things into the Tupperware, you will find that in the Tupperware, the bottom of the Tupperware is smooth. So if you pour a can of sardines from the tin into the Tupperware, you will find that the shape of the sardine will not alter during its transfer from the tin into the Tupperware, because the Tupperware is smooth surface and soft. Whereas the brain, the floor of the brain, the ceiling of the brain, the side of brain, if you can ever appreciate it, you can always Google that, you will see it has many sharp edges. So when you shake your brain, my head now, my brain is moving all over the place, front to back, back to side, but I am not cutting my brain from the sharp edges that make the floor, the ceiling, and the wall, because there is CSF, cerebral spinal fluid. So that acts like a shock absorber. But in very severe traumatic brain injury, that's why we ask you to wear a helmet, even riding a bicycle, even roller skating, because when you fall down, the external impact onto the skull will go to the 5 centimeter, depending how thick your helmet is, So that will dampen the effect onto the brain, so that the brain will not rock too much and get cut by the structures within that make the floor, the ceiling, the roof, the front and the back of the skull. So that's very important. So when we have a road traffic accident, this is what happens. Because in the brain, when we have an accident, the brain moves from front to back, or back to front, or from left to right, or right to left. And because there is cerebral spinal fluid, the brain can rotate around the brainstem. So you have the cerebrum connected to the brainstem. So during your drawing of the brain, so you drew the brain, you drew the brainstem, you drew the cerebellum. So you see the brain, the supratentorial structure, which is the cerebrum, is attached to the brainstem. And the brainstem goes through a small little hole in the skull called the foramen, okay, before it joins the spinal cord. So when you have an accident, you're falling, your brain not only moves from front to back, side to side, it will also rotate around the brainstem. It's like when you want to dry your socks, it's all wet, you do wringing of the socks so that you wring and you push all the water out from the socks. So the socks become drier so that you're able to hang it out in the hot sun to dry. So that happens also in road traffic accidents, where the traumatic brain injury patient will have a ringing effect, W-R-I-N-G-I-N-G, where the brainstem is twisted left and right. And that will also cause injury. So the tracks that communicate the gray matter to the brainstem, to the midbrain, to the spinal cord are also involved in the injury. Okay? So when you have injury, you have primary injury, you have secondary injury. So when I fall off my bicycle at 2 o'clock, that is my primary injury. Okay? After a few minutes, a few hours, a few days, I will develop secondary injury. And the primary injury is okay. I can withstand the primary injury enough to go into my car or ride my bicycle to the hospital. By the time I reach the hospital, I cannot move my arm, I have a headache, I might be comatose, I might be confused. That's a secondary injury. So I hope you understand that is the complicated mechanism. So when you have traumatic brain injury, it's only not one side. Right side is injured, left side is normal. Unfortunately, in Malaysia, most of the time when we have a brain injury, we only do CT scans. Not many hospitals, not even private hospitals, do MRIs of the brain to look at your brain injury after a trivial fall from a bicycle, roller skating, you got hit by a golf ball or hockey stick. Nobody does an MRI. They will only do a CT scan because that is the international recommendation. But if you were able to do a MRI, you'll be surprised. You will see that there will be, just after a trivial injury from a rugby tackle, for example, you may have lots and lots of injury to the brain circuit. So in the brain, you have circuits. I would like to put S here, brain circuits, So the reference is this book, Translational Research, Neurobiological Consequences of Traumatic Brain Injury. You can Google this, don't worry. So what you will see is in our brain, we have the frontal lobe, we have the midbrain, we have in between the frontal lobe and the brainstem, the thalamus, okay? We have the orbits, which is the eyeball, okay? We have extreme in front, right in front of just above your eyes is the dorsolateral prefrontal cortex, okay? And just very close towards your ears, you have the medial frontal cortex, okay? So the frontal lobe here is such an important lobe. Again, I had to remind you, important lobe, that this lobe even though it is not as important as the brainstem, but it's important in many functions. And then you have the thalamus. So I think some of you have read about the thalamus, and I think maybe Dr. Regu or Prof. Zamzuri has taught you about the thalamus, the caudate and the putamen, which you have learned. And then you have the globus pallidus, which is a big structure. So you have globus pallidus interna or internus. We use a lot of Latin in anatomy. So it's internal globus pallidus, and globus pallidus externa is external globus pallidus. And you have this little structure called substantia nigra. Nigra means black, substantial means substance. So black substance in the brain, and any destruction of this substantia nigra can cause you to have Parkinsonism or Parkinson's disease. And then you have the thalamus, a big structure. So you see that from the frontal cortex to the thalamus, the distance is about 6 centimeters. So just imagine a golf ball hits your head. Of course, the frontal cortex, the gray matter will fall the brunt of it. And let's say you're hitting the football into the goal, you're hitting from the front part of your skull, of your head. Therefore, you are shaking all the frontal cortex. Okay? And therefore, you're going to disturb some of the circuits between the thalamus to the frontal cortex and the frontal cortex to the caudate nucleus and putamen, and indirectly with the striatum talking to the globus pallidus and subthalamic nucleus with a feedback back to thalamus. So you will see the excitatory pathway and the inhibitory pathway. So the thalamus is an excitatory pathway, So it is very important. If the thalamus is sick, the frontal lobe is healthy, you will not be able to do social work, executive function, and you may also lose your motivation. Your thalamus is healthy, but your frontal lobe is not healthy. Normally, after road traffic accident, the most commonest lobe to get involved is your frontal lobe and your temporal lobe. So all is 1, 2, 3. The orbitofrontal circuits, the dorsolateral prefrontal circuit, and the medial frontal circuit will all be involved. Either there will be swelling of the circuits, there can be destruction, total destruction of the circuits, there can be partial destruction of the circuits. Some of the circuits can recover if we can give treatment early, like drugs and all that. The best treatment for circuits, in fact, is oxygen, but you have to give very high level of oxygen. And then you have the inhibitory pathway, so the globus pallidus and the globus pallidus externa and subthalamus nucleus, they will inhibit the thalamus. So for example, this is like a policeman. The globus pallidus, the globus pallidus externa, the subthalamus, they are like a policeman preventing you from driving from Selangor to Kota Baru, because you're now in the red zone or whatever zone. Even Kubang Krian now since the last 7 days has become red zone. So you can see that without the policeman, the inhibitory, the thalamus will become high and mighty, will become naughty, and it will continue to have excitation, excite the frontal lobe. Remember, our brain needs to rest. So continuous excitation without inhibition is not good. Just like we need to sleep. The sleep will cause an inhibitory pathway, and that will ask the brain to relax. If we have excitatory pathway all the time, drinking coffee will stimulate the excitatory pathway, drinking tea, doing exercises, doing yoga, doing whatever, will excite the excitatory pathway. The lines will become very thick, and there will be more, executive function, motivation, behavior. So that's how coffee works anyway. So when coffee increases the thickness of these lines, you are more motivated, you have better executive functions, and you can have better empathy and socialization with your partners. So if any of these circuits are involved or destroyed by trauma, from a road traffic accident, there can be a blood clot here from the trauma. There may be shering, S-H-E-R-I-N-G, of the white matter tracts, because these are all white matter tracts. Okay, frontal cortex will consist of both grey matter and the white matter tracts. And this is also grey matter and white matter tracts. This is grey matter and white matter tracts. So any of these white matter tracts are interrupted by trauma, then you will have problems with the frontal subcortical circuits. A very important circuit in road traffic accident. If you have any experience with family members or people that you know of, when there is a interruption of the circuit, the person will lose motivation, he will be depressed, he will not be able to have full executive function, and his social compartment will be very bad. He will not be able to liaise with his colleagues, etc., etc. And sometimes if this is very bad, then the patient or subject may show Parkinson-like phenomenon. He will be walking slowly, he'll be shaking, having tremor because of the involvement of the substantia nigra. The number of the receptors in substantia nigra would have decreased, and because of that, it's unable to stimulate the thalamus. The thalamus is unable to stimulate the frontal cortex, and the frontal cortex cannot then go to the striatum again. So this whole circuit is not functioning well at all. Okay, so this is so again, I want you. This is very important. I want you to go back to your internet, because you don't have a brain specimen. I want you to look at where orbitofrontal cortex is. What the gyrus and sulcus are important. They are found in the orbitofrontal area, right and left. Remember, you have two brains, two hemispheres. I want you to look at the dorsolateral prefrontal area. What are the sulcus and gyrus there? And I want you to look at the medial frontal aspect also. What sulcus and gyrus are present there, because it could be very much related to your exam. Okay, so now we go to the second slide about brain circuits and trauma. So when you see a patient or client who is involved and who was a victim of a road traffic accident, he will not come to you, like Spock in Star Trek and say, okay, my cingulate and parietal cortex is kaput. No, they will not know anything about anatomy. What they will know is they will complain. So when they complain and you ask questions, and you will find out that they have problems with working memory. Then they have problem with short-term memory. Whatever I told you 5 minutes ago, you will have forgotten already. Working memory is what you learn. Let's say today you learn how to assemble a machine, an engine, and 6 months later, you cannot even remember how to assemble an engine. And you lose attention. Okay, so that's also a part of working memory. And then speed processing. Okay, so not only do you lose the frontal subcortical circuits, but there are other circuits involving other parts of the brain. So this is most important and most common. So you have cognitive deficit and dysexecutive syndromes. So under cognitive deficits, you'll find that the dorsolateral prefrontal parietal lobe, cerebellum is also involved. So a trauma to the cerebellum can also cause deficit in working memory. Subcortical white matter. And how do they correlate that? They correlate to the neurotransmitter. Because you have a pathway, you have grey matter, you have white matter, but what's most important in the grey matter is your dopamine, neuroepinephrine, and maybe even acetylcholine neurotransmitter, which is important in working memory. So that's why we have drugs to improve the dopamine neurotransmitter, to increase norepinephrine, also to improve acetylcholine. Okay, and this overlaps with attentional deficit. So short-term memory attention, the frontal lobe, hippocampus is important. Frontal, cingulate, and parietal lobe is important. And there's a subcortical white matter. And most important for attention is your reticular activating system, is the one that gives you consciousness. So for short-term memory, acetylcholine is so important. So that's why a lot of the drugs for dementia, for Parkinson's disease and all that, they involve modulating acetylcholine. Okay, and even when you're drinking Centella asiatica, which is a herb, that also affects your acetylcholine as well. It tries to increase your neurotransmitter. So those are exogenous, means to say that the sources come from outside. But acetylcholine is made in your own body. All this is made in your body. This is natural. It's very difficult for you to make dopamine, swallow the dopamine, and then it will improve your working memory. Because by the time you swallow it, your hydrochloric acid in your stomach will already digest all these neurotransmitters. So these neurotransmitters have to be given either, it has to be given intravenously if possible, or some other method. If not, it will not stay in the brain. So processing speed is subcortical white matter tracts. Again, you see acetylcholine is everywhere. So the person who has a road traffic accident with traumatic brain injury will have attentional deficit. He will have problems with processing, arousal if it's very bad, very severe, very slow in thinking, The dysexecutive syndromes, that's common, is your orbitofrontal subcortical circuit, where there's disinhibition and social compartment. That means to say you may walk around naked, showing off your genitals to everyone, because you have no inhibition. You have this no. So you say many things. You swear at people. You can even be a rapist, and this is because of the problem of the orbitofrontal subcortical circuit. If the rapist goes to court and the lawyer is smart and he's able to prove that the orbitofrontal subcortical circuit is kaput due to a road traffic accident, maybe the person who was the rapist may get scot-free, because the rapist didn't become a rapist because he wanted to, but because the circuit involving the orbitofrontal was kaput. And this involves GABA, serotonin, catecholamines, lots of emotions there. Cognitive dysexecutive, dorsolateral prefrontal cortex, also overlaps with cognitive deficit. Motivation has many areas. Medial frontal cortex, cingulate anterior part of the cingulate gyrus, okay, involves dopamine and noradrenaline, and you will present as apathy. That means you say you're sitting very quiet there, not doing anything. I can put a snake in front of you, I can shout at you, I can scream at you, I can, bring a knife to your neck, but you are sitting there quietly because you are apathic. You have no emotion. Psychiatric disorders, very important, lots of them. Depression, left anterior frontal cortex, which affect the temporal limbic circuits, okay, associated with poor short and long-term outcomes. So most of the road traffic accident clients or patients will have depression. Unfortunately, we do not have enough psychiatrists in Malaysia to manage them. So this is the epidemic now. Substance abuse. So components of reward circuitry. So you will find that The nucleus accumbens is the pleasure nucleus. When you smoke, when you eat good food, when you are addicted to the internet, the nucleus accumbens is a small nickel nucleus, which is very dominant in substance abuse. So this is what happens because the reward circuitry is overloaded. I mean to say, even sweet, smoke, drugs, you cannot control. There's no negative feedback. Post-traumatic stress disorder involves the hippocampus, temporal lobe, amygdala, temporal lobe, medial and orbitofrontal cortices, temporal lobe. And this will give you cognitive deficit. So you will see that from a road traffic accident, even a mild road traffic accident, mild brain injury, you will see that you can have many destructions of these cells. Okay, so some people say that you need to destroy about 20%, 10 to 20% of millions of these neurons to be able to give all these deficits. So that's why it's very important. So people are now doing research to see whether we can put stem cells, and the stem cells can become gray matter or white matter and replace all these regions that have been destroyed by trauma. Okay, so this is a picture, okay, that shows the brain, and it shows this all confirmed by MRI. So you can see the dorsolateral prefrontal cortex is very important. This is a very common area to be involved in road traffic accident because you hit your front part first, your orbitofrontal cortex, so your dorsolateral prefrontal, executive function, working memory, sustained and complex attention, memory retrieval, abstraction, judgment, insight, and problem solving. And the orbitofrontal cortex is emotional and social responding, social compartment. Your temporal pole, so everything is very, very front, because when you get into an accident or hockey accident or whatever, these are the areas of the brain that will bank onto the front part of the skull. So temporal polar cortex, memory retrieval, sensory limbic integration. Your cerebellum, coordination, working memory, mood regulation. The amygdala, emotional learning, memory and fear conditioning. The ethno-rhinal hippocampal complex, declarative memory, sensory gating attention. Ventral brainstem, arousal, ascending monetary neurotransmitter. So even the front part of the brainstem. And all these areas in front are the areas that are squashed during the accident. So these are the gray matter areas that get involved. And then after they get involved, they go and disturb all these circuits. And the most dominant circuit that get involved is the frontal subcortical circuits. Okay, so that's the story of the circuits involved in traumatic brain injury or head injury. Any questions? Any questions you want to ask?
Prof?
Yeah, go ahead. Go ahead.
Usually, I'm talking about the rehabilitation process, right? After a patient had a traumatic brain injury, regardless whether it's a motor vehicle accident or due to fall and all that, how long does it take for the brain to be stable? Because some people say the first 6 months, the brain changes over time, and the rehabilitation process might not be so great because some patient were still agitated, impulsive, some kind of behavior that is difficult for the patient to do rehabilitation.
Okay, good question. So head injury or brain injury have got three different stages. You have mild head injury or brain injury. You can have moderate, and you have severe. So in mild, some of these circuits are intact, but even though the circuits, the wiring is intact, the destruction has reduced the number of white matter tracks connecting to the grey matter. And then if you have moderate and severe head injury, more tracks are involved. And sometimes the whole brain is involved. Right brain, left brain, frontal lobe, parietal lobe, occipital lobe, temporal lobe. So as more areas of the brain are involved, it will take a long time for recovery. So for mild head injury, usually if you use MRI, psychological tests, which are paper and pen tests, and also we can map the track. You know this track that you see these lines, you can look at the tracks. So this is not using functional MRI, but using tractography. So track is track. Tography is picture of the white matter track. So with a good MRI, you're able to look at the volume, the thickness, the length, the width, the breadth of the road, the white matter track road. And if you do the MRI 4 weeks after injury, then you do an MRI 6 months after injury and 1 year after injury, you will see that some of the roads have increased their volume because of the rehabilitation. Some of them have not increased their volume; they are destroyed. So the road from PJ to Shah Alam is totally destroyed. But because of brain plasticity, there is a bypass from PJ to Shah Alam. Instead of going through the toll, it goes through some small little pathways, tracks to reach Shah Alam. And you can see that even happening months or years after the trauma. So that depends on the degree of rehabilitation. Because all these things need stimulation. And if you look at this slide, to stimulate the neurotransmitter and to stimulate the tracks, you need rehabilitation. If you do not do any rehabilitation, there will not be any recovery. There will be spontaneous recovery. Just like if you do not do anything to a road, the road will still be there, but the road will be full of potholes. So during the rainy day, the potholes will fill up with water. On a dry season, the potholes will be there, but there won't be no water. You can start the car, you still can drive over the potholes, but it will be a bumpy road. So just like that, when you have a bumpy road, you have all these problems. The degree of working memory loss, the degree of short-term memory loss, etc., will be enhanced. So it depends, therefore it depends on the grade of the injury. Right now in 2021, if you want to see how the brain is doing, you have to do MRI. A CT scan will not show you the grade of injury of the brain, and the MRI will show you the grey matter, the white matter. And some of these neurotransmitter can be measured with MR as well. It's called MR spectroscopy. You can measure the chemical amounts in the cells. So with a good MRI, many things can be done. But measuring the brain with good MRI doesn't mean anything unless you exercise the brain, stimulate the brain, which is injured. Does that answer your question? Was it Asmarul just now asking the question?
Yes, Prof. Thank you very much. It's just that I don't know how much the myth about spontaneous recovery. You know, since people say they can have spontaneous recovery, some patient may not have spontaneous recovery.
Yeah, spontaneous recovery happens in mild traumatic brain injury. In moderate and severe traumatic brain injury, spontaneous recovery does not happen. They have done studies in this. There are lots of papers on spontaneous recovery in mild traumatic brain injury. Tapi in mild traumatic brain injury also they have got many points. We use the Glasgow Coma Scale which is 15/15. If you want to Google, all doctors when patients get involved in traumatic or head or brain injury, they want to know the severity of the head injury or brain injury. They use this score produced by Professor Janet in Glasgow, in Scotland. This is a score which is very, very old, more than 30 years old. So a score which is 15/15 would mean that the patient would recover very well. But a score which is 14/15, the patient may take 6 months to recover. And a score of 12/15, the patient may take 1 year to maybe 2-3 years to recover without doing imaging. So in the good old days, that is what they found out. So that is depending on the severity of the injury.
So the GCS score the range is very small, only 1-point scale to determine the recovery process. So that means those who score 10
for the recovery process, they use Glasgow Outcome Scale, GOS.
Okay.
To see recovery, you use the outcome scale.
Okay.
To look at injury in the first day of injury, you use Glasgow Coma Scale. So there is a Glasgow Outcome Scale, GOS. But the GOS that only looks at your corticospinal tract and your spinothalamic tract and some cognitive function. The GOS does not look at all the circuits. You understand?
Okay.
Nothing beats like a good psychological paper and pen assessment and also MRI to see how the brain is recovering. Okay, any other questions?
Thank you, Prof.
Because we got two more topics. I want you to understand this first.
Professor, this is Elif Mankius. Good afternoon. I would like to, is that whiplash? Is this also some kind of, can we call it traumatic injury, or this is...
Can you repeat your question again?
Whiplash during the road accident.
Oh, whiplash.
Yes.
Okay. Yes.
So,
okay.
Yeah.
Whiplash injury is an injury that involves your neck. So therefore, when we say head injury is whiplash injury. And when you have a head injury, because your neck has got many nerves, it has the nerves from your neck cord, spinal cord, has got at least 7 nerves coming out from right and left, both motor and sensory from your neck, which are coming out from your spinal cord. The spinal cord is connected to your brainstem, and your brainstem is connected to your thalamus, and the thalamus is connected to the frontal cortex, etc., etc., as you can see in this diagram. So a whiplash injury, which caused trauma to the muscles and the nerves of the neck, will send impulses, and it will send you inhibitory impulses to the thalamus and other parts of the brain, and the thalamus will then, these arrows will become pretty thin. The excitatory pathway will decrease. The excitation will be decreased, will be reduced to maybe 50% or less of its function. And then with whiplash injury, the patient will become depressed. He can have less motivation. He can have abnormal executive function, and even involve a social interaction with peers. And then when this is abnormal, it will go back to the striatum, the impulses, the excitation will be decreased. And then going to the globus pallidus and subthalamus nucleus, it will infect even the movements. You are not going to move as normal, as fast as you used to move when you did not have a whiplash injury. And difficult to image whiplash injury because the circuit is very long, because the circuit starts from the spinal cord, the cervical spinal cord, goes up. It usually follows the spinothalamic tract. the spinothalamic tract will end up in the thalamus before it goes to the cortex. Okay, and then it will go to the frontal cortex. It will go to temporal cortex. Even with people with whiplash injury, will have problems with memory. So memory processing, working memory. So a very severe whiplash injury and it's not involving the brain. The brain is totally normal, but the cervical cord is not normal, and the muscles around the neck are not normal. They will cause cognitive deficit and also cause dysexecutive syndromes as well. You're right. But I'm not covering whiplash injury because I'm talking about brain. But whiplash injury is a very important component, and it's very important because in Malaysia we ride motorbikes more than cars, and when we drive cars, we don't put our seat belts. So not only is the brain, the frontal lobe moving forward, but your neck is also moving forward, and it's stretching all the nerves in your neck muscles, and the nerve that comes out from your cervical spinal cord. Does that answer your question?
Yes, thank you, Professor.
Okay, next. Any questions? No questions. Okay, so just to tell you, I always like to make things exam oriented because people learn because they want to learn, but there can be exam questions asking about the anatomy of the frontal lobe. So I hope you go back, study the drawing that you drew, okay, especially the front part, okay, and know about the gyrus and sulcus of the prefrontal cortex, the orbitofrontal cortex, the temporal pole, So these areas are very important because we can just put a label here, A, and we ask you, what sulcus is this? What gyrus is this? Okay. Of course, you have to self-learn this, but in the next few weeks when we have revision of anatomy, I already bought my GoPro from with USM's budget because if you are unable to hold the brain, then I have to show the brain, so I have to wear a GoPro. And with that GoPro, hopefully you will see the cadaveric brain better. Okay. Your exams, unfortunately, will be done all online because of COVID. So you are not going to have a hands-on anatomical examination. But we will be taking photographs of brain specimens. Therefore, you would need to know the sulcus and gyrus. Not only, this is an imaging. It's imaging. So in your exam, you will have some exams that show you pictures like this, which are from MRIs. Or you will have exams which show photographs from the cadaveric brain. Okay? So, but no worry, we still got a few more lessons after this, so you don't have to panic, but these are the things that you will learn and get yourself prepared for the exam. Okay.
Professor,
Any other question?
if you use the name lead wrong spelling, for example, because so many Latin word that callosal, sulcus, fossa. If we do that kind of mistake, how that affect our scores?
Don't worry about because if you go to Great Britain or you go to countries that are not familiar with Latin, like China, Japan, Indonesia, India, you will see that they spell everything upside down. But as long as the acronym is correct,
okay,
so
okay.
superior temporal lobe,
Okay.
STL.
Perfect.
You may spell temporal TAMPERUL. We still mark you correct.
Okay, thank you very much.
We're not looking at the spelling, we're looking at the acronym. So acronym is more important. But if the superior temporal lobe is inferior parietal lobe, then that is a 0 mark.
Oh yeah.
But if you spell parietal as P-O-R-I-T-U-L, parietal, you still get full marks.
Perfect.
Don't worry
Thank you,
about
sir.
that.
Thank you.
That's a list of our problem. Okay, any other questions before we go to the next topic? No questions on the, so please go back, look at your prefrontal cortex, look at your diagram, okay? And then after that, discuss with each other. It's difficult to study anatomy during the COVID period. I pity the medical students because they have to study anatomy of the whole body, and they can't even have access to the cadavers. So that's going to be interesting. But never mind, that's the COVID problem. Okay, next topic is brain circuit post-traumatic stress disorder. So just now we talked about traumatic brain injury or head injury. Now we are going to PTSD. Very commonly, people use these words left, right, and center, especially our friends from psychology and our cognitive neuroscientist friends, and then, our psychiatric friends as well. So the most important keyword here is stress. So any stress that comes in, and this is post-trauma. So traumatic can be like you're having a road traffic accident. But if today you are robbed by two robbers, I saw in the newspaper somewhere in Damansara, one 71-year-old guy died after he was hacked by a parang. His wife, which is also 60-something years old, was admitted in ICU. And let's say the wife survived. And she was discharged from hospital. She went back home. This is a trauma. She was not involved in a road traffic accident. Nobody hit her with a bicycle or with a football or motorbike, but she was robbed. So that is psychological trauma. You have no lacerations or marks on the head, but you still have trauma. A person was raped, that's also trauma. You have child abuse, that's also trauma. So when we talk about post-traumatic stress disorder, it can be trauma that you can see the scars, and it can be trauma that you cannot see the scars. But they all lead to stress. And this is a coping, that is very bad coping mechanism for the stress. That's why they call it a disorder. And they use the post-trauma because, of course, it's after the trauma, not before the trauma or during the trauma. This is a big problem in Malaysia, big problem in the world, okay? People who get bullied, even in school, that's also a trauma. So nearly every human being, normal or not normal, has got a traumatic experience, believe it or not. So this traumatic experience can give you different grades of post-traumatic stress disorder. So why do you want to understand the brain circuits? Because nowadays in 2021, when you know the brain circuits, you can treat the brain circuits. How do you treat the brain circuits? Right now in 2021, you have ultrasound stimulation, electrical stimulation, magnetic stimulation, etc., etc. Okay, or other stimulation. It can be yoga, it can be dancing, it can be music therapy, whatever. Anything to go to the brain circuit, and how to reduce the effects of a bad brain circuit. When you have a bad brain circuit, your disorder becomes worse. So this is very important for cognitive neuroscientists and also psychologists and psychiatrists. Okay. So this is a nice paper. If you are crazy, very, very into PTSD, you can read this nice paper published 2 years ago by Fenster, okay, in Nature. Nature Review. Nature is, of course, a hot, high-rank paper publication. They reviews all the publications that have been published before, good and bad, and then the author will then present their findings. So you see, even mouse, the good mouse, cat, dogs, animals that have been tortured, they also have PTSD. So this paper reviews mouse to men. That's why it's not only men alone, you know. So when you look at the different brain parts, so here they have, when you have PTSD, you have many psychological problems. Number one is avoidance. A lot of people with PTSD tend to have problems with talking to people, so they avoid social contact, you know, intrusions, altered cognition and mood, altered arousal and reactivity. These are the four main problems in post-traumatic stress disorder. So it's very difficult to do experiments on post-traumatic stress disorder when the human being hasn't got it. And it's very unethical to do experiments on PTSD in humans who do not agree to be experimented on. So most of the scientists in the world, developed countries, developing countries, they have to choose models. So unfortunately, when men cannot be used as a model because they are, you know, they have all these problems, so they disagree to be a lab rat. So we have to use a real mouse or a real rat, and we have to choose the rodent, you know, because the rodent's area may be slightly different from the human, but that is what we call comparative cognitive neuroscience, where when we study rodents, we have to understand the anatomy. Okay, so when you look at humans, you may forget about the rodents, since today we are talking mainly on humans. You will see the areas involved. You see for the intrusions. So you will see that the area involved are the ACC, cingulate cortex, the anterior cingulate cortex. R is right. Right. Kalau in Latin you have sinistra and dextra. So V is ventral, M is medial, P is prefrontal cortex. Okay. So ventral, medial, prefrontal cortex. These areas are involved in PTSD, which is involving intrusions. Is Shamimi there?
Yes.
Shamimi? Okay.
Yes.
Can you open your hand? Are you using handphone or laptop?
Laptop.
Okay, you have a handphone now?
Yes.
Okay, I want you to Google intrusions PTSD. This word, intrusion. What is the meaning of intrusions? The definition of intrusions. Tell me that in 5 more minutes. That's the disadvantage of being the group leader. Boleh kah? Shamimi?
Prof, intrusion of
Intrusion associated with PTSD. What is the definition of intrusion?
is the inability to keep memories of the event from returning.
Well, you tell me 5 minutes from now. You read what it's all about, especially in PTSD.
Okay, Prof.
And you tell me at 4:10 afterwards. Okay?
Okay.
Okay. And then you see avoidance. Avoidance in PTSD involves the cingulate area, the hippocampus and amygdala. And then altered cognition and mood involves a bigger area, thalamus, okay, the medial prefrontal cortex, and also in altered arousal and activity, you have the VP, just like this green area here, the dorsal anterior cingulate cortex, okay, and the orbitofrontal cortex and the amygdala. So these are small little nuclei or areas in the brain. So remember, if I was involved in a road traffic accident, so you say post-traumatic stress disorder. Okay. So most of these areas, you know, if the psychologist does a test and he finds that this patient or subject has got problems with avoidance, intrusion, cognition is altered, mood is abnormal. He is not, he's arousable, but he is as inappropriate arousable and reaction. You talk to him, he screams at you, he hits you, he whacks you, he fights you, he kicks you. So in traumatic brain injury, where I have a motor vehicle accident, that means to say most of these areas of the brain are involved. Okay. But let's say you are abused as a child, or you were raped by your stepfather since the age of 15, and you're now 40 years old. Or you were robbed 20 years ago, and from the day you were discharged from the hospital until today, you still have all these 1, 2, 3, 4 problems. The problem right now is not destruction of these areas, but the volume of these areas. Remember, like bodybuilding, when you go to the gym, you bodybuild, you want to lift a chair, the weight of the chair is 25 kilos with one arm. You will go to the gym, do lots of exercises. Maybe after 6 weeks, you have very strong right arm and left arm, biceps and triceps and all that. You're able to lift this 25 kilo chair in 2 seconds. No effort at all. No problems at all. Okay? Now, you stop exercising. You come back 6 weeks later, your muscles have all come back to normal size. And you try to lift the chair. Very difficult. You'll be struggling. You might need someone else to help you, for example. So, in people who have got no brain trauma, like a road traffic accident or stroke, their area, the volume of this light blue area, light green area, purplish area, yellow area, has decreased in size. Not increase, getting smaller. So not only if it's connected to the appropriate gray matter, like you see here, on altered cognition and mood, but also the white matter tracts have all reduced in volume. And because there is no excitation, there's only inhibition, this volume stays forever small. So forever and forever you have the problems of avoidance, abnormal arousal, abnormal cognition, and abnormal intrusions. Unless you do what? You give drugs, you give behavior therapy, psychotherapy, maybe even stimulation using electrical, ultrasound, magnetic, whatever, you know. So this will then stimulate these areas to increase in volume again. So that's why you want to know about the circuits. Why you want to know about the circuits? Because in 2021, when you know that Mr. A has a PTSD and his main problem is altered cognition and mood, then you know that you can target these areas, the medial prefrontal cortex, the cingulate area, the thalamus, the amygdala, hippocampus, by putting a probe on the skin of your head, stimulating it with current, direct current, indirect current, magnetic, whatever, ultrasound, you know. Or you can do music therapy. The music therapy will come in through circuits that share the same tracks for music, for listening, for enjoyment, and certain music therapy may be able to increase the volume of the gray matter and the white matter tracks. So this is what this is why we have to know about cognitive neuroscientists and clinical psychologists, because clinical psychology is not like how psychology was practiced in the era of Jung and Sigmund Freud, where there was no imaging. Now with imaging, a lot of psychologists, clinical psychologists are using neuroimaging, especially clinical neuropsychologists. Like USN's program for clinical neuropsychologists, we will teach them when they come into the program as full term, how to examine patients, how to read an MRI, how to find out what is the problem. So, and the stimulation can also be done eventually by a certified clinical neuropsychologist. Okay, Shamimi is still there?
Yes, Prof.
Tell me the story about intrusion.
Basically, intrusive is actually re-experiencing symptoms after the trauma, such as intrusive thoughts or recollections, recurrent dreams of the trauma, and flashbacks of the trauma. So there are few symptoms, which is the flashbacks or dissociative reactions, where it seems as if the trauma is reoccurring. And then distressing dreams and or nightmares related in content or emotion to the trauma. Intense psychological distress that reminders of the trauma, and intense physiological distress, often referred to as body memory or body cues.
So are you fearful when you have intrusion? Are you afraid of the tiger or you're not afraid of the tiger?
I think from my understanding, like afraid of the tigers. And
you're more afraid of the tiger.
Maybe the experience that I have with the tiger associate
So
with her trauma.
if you were robbed 10 years ago, someone came to your house, brought a parang, broke into the house, okay, cut your face, and then stole your money and ran away. So, how do you think, what kind of intrusion that person will have?
I think it's the flashbacks. If like, let's say if it happens 10 years ago, then most probably the flashback will be re-happening again in the mind.
Yes, then you'll be fearful.
Yep.
You'll be scared. No?
Yes.
You takut, scared, fearful. So that will come from the amygdala. Amygdala is, we love soldiers who have got big amygdala, huge amygdala, because you become super soldier. They're not afraid of anyone. You just go and, run all over the place and kill people, maybe. So when your amygdala is shrunken or small in size, then you'll find that these soldiers become cowards, So amygdala is very important for that feeling of fearfulness. So your flashback, etc. So now you can now see why the brain circuit for PTSD is so important. Number one, it's common. It's very common. You can have a mild form. You're bullied in school. So if you're bullied in school, you're raped in school, you're beaten, etc., etc. So all these areas of the brain will be and can be affected. Some can be affected more than the rest. So how does one look at this? Then you have to do, for the white matter, you have to do tractography. For the gray matter, you do functional MRI. So you show to the client or subjects images that will see whether he has problem with his intrusions, whether he has problem with avoidance, which is having problems with arousal and reactivity, and problems with cognition and mood. And sometimes you don't even need someone to have a road traffic accident. A normal university student who says that I am completely healthy may have different levels of intrusion, avoidance, altered arousal, and altered cognition. Especially arousal, avoidance, and intrusions. He may be cognitively correct, but he may have different levels of reaction to intrusions, avoidance, arousal, and activity. So even normal university students can be studied to see what's happening to their brain. You can not only now in 2021 use MRI, tractography, but even you can use the good EEG, electroencephalography, or event related potential. Okay, those are, but it's very cortical. So some of them are good to study, like altered cognition and mood. EEG will be superior, and maybe for ventral prefrontal cortex intrusion, some images that stimulate the gray matter that involved in ACC and PFC is important. But singulate will be very deep. It will be too deep for the EEG to study. You may have to use functional MRI or other modalities to study avoidance in PTSD. Okay, so again, you have a map here, a map of post-traumatic stress disorder neurocircuits. So you can forget about the rodent unless you want to do an animal study in the future. Maybe the cognitive neuroscientists, master students want to do a rodent study where they want to study, kratom, drugs, compounds that you take, and this will, modulate the fear extinction and the avoidance behavior. So you see for intrusions, you have again the same diagram. So all these areas, insula, hippocampus. So you have cortical and subcortical. Okay? And then you have, under avoidance, you have cortical and subcortical. So when we say discuss about brain circuits involving post-traumatic stress disorder, you may want to use this type of diagram, for example, a mapping diagram, where you put the psychological problem, okay, and then the area that's involved, cortical, subcortical, okay, avoidance, cortical, subcortical, and these are the red areas indicating how important they are. The insula, the amygdala, the anterior cingulate cortex, the ventral medial prefrontal cortex are very important in diseases that involve intrusions. In diseases that involve avoidance, Shamimi, are you still there?
Yes, Prof.
Poor Shamimi. That's why lah, bila jadi group leader, this is what you got to do. Or maybe Shamimi can ask someone else. I see Ditya, are you there?
Yes, Prof, I'm here.
Okay, Ditya, can you look at the definition of avoidance? Avoidance in post-traumatic stress disorder and tell me in 5 minutes time?
Yeah, can.
Okay, come back to me. So we just want to know what you understand, with the words avoided. Just now we have the word intrusions. Okay. So the altered cognition and mood, you have again cortical and subcortical, altered arousal and activity, cortical and subcortical, and the areas that's important. These are the red areas where, when they are involved, then this will definitely, either the insula is destroyed by accident, there is a stroke in the insula, or because the post-traumatic stress disorder is so severe that the volume of the insula, hippocampus, amygdala, thalamus, striatum is reduced in size. So it's very easy for them to have all these cortical abnormalities and subcortical abnormalities.
Professor, can I ask one question?
Yes.
This post-traumatic stress disorder, it can take longer time, like, for example, 5 to 10 years before the person really can feel it?
Yes, it can.
Because we have cases after the Balkan War that so many soldiers didn't realize that they had this disorder, and they start to go to the rehabilitations after 5, 10, but they already burn out. They start to see the graves and everything. So it's like it took very long time before they started to recognize something is wrong.
That's right. That's why I say in post-traumatic disorders caused by road traffic accidents, caused by stroke, caused by infection or whatever you want to call it, that represents the trauma. There is destruction of the neuronal cells in the white matter. But in when you're raped, when you are bullied, and all the other diseases associated with it, time will tell, and some of these changes take many years. Because it takes neurons many years to shrink. And remember, there is excitation and inhibition. So the inhibition effect takes many years because of the neurotransmitter. So as the patient gets older, the dominancy of the neurotransmitter onto the brain circuit is also important. So there's a lot of component of depression, especially, and depression is from mild, moderate, severe. So when you start depression at the mild level, or intrusion at the mild level, or avoidance at the mild level, or altered arousal activity at the mild level, the changes are too minimum for the person himself to recognize it, or even the psychologist or the psychiatrist or even the wife of that human being, that soldier, to recognize it. It takes many years. That's right. And some of it is genetic. Some people have these problems very quickly, and some of these people they have this gene, expression that they exhibit it many years later. So it's all about genetics as well. Any other questions?
Prof,
Yes.
can I ask you an opinion about a case?
Maybe after the end of the lecture, and I hope you are sworn to secrecy, because when you talk about cases, we do not want to know the name of the person,
No, I won't. It will be very confidential.
your patient, whatever you guys have.
It's related to brain injury.
Secret. Yeah. Okay, never mind. Let me finish this first.
Okay, sure.
Then at the end, we will discuss some more. Okay, so especially our clinical psychology friends, they are very familiar with DSM-5. Okay, and so in DSM-5, you have DSM diagnostic criteria, and therefore the brain circuits can be related directly right now in 2021, not by DSM itself, but by the clinical psychologists or the cognitive neuroscience. Because the DSM-5 diagnostic criteria, intrusions here you have all these dreams, criteria B, criteria C for avoidance, and the negative valence system that the psychologist or the cognitive neuroscience person, after interviewing and doing tests, will be able to find out what's wrong with the subject. So let me think. I see. I want to wake up someone. Hafizah Zainul, are you there?
Yes, Prof, I'm here.
Okay, can you go? I think you're using your laptop, kan?
Yes. Yes,
So
Prof.
use your handphone. Okay, handphone or laptop, whatever. Tell me what negative valence system and positive valence system means. Are you studying cognitive neuroscience or clinical psychology?
Clinical psychology, Prof.
Lagi bagus. If a clinical psychology doesn't know what valence means, what negative valence mean, and what positive valence mean, then it will be very difficult for you to become a clinical psychologist. So I give you about 5 minutes,
Okay, Prof.
and then you read this out, and then in 5 minutes you just tell me what you understand from negative valence system and positive valence system. Okay? So if you look at this diagram, you see the cognitive system involved. Okay? Attention, declarative memory. Okay, this is something like from the diagram just now. attention and cognitive control, and then the social processes involved in it, and the arousal and regulatory system involved in the different DSM diagnostic criteria. So for those who are familiar with DSM or are going to be familiar, especially the clinical psychologists, I know the cognitive neuroscientist does not use DSM-5 so much compared to the clinical psychologist. You will see that we are going to be able to interact imaging to DSM-5 diagnostic criteria soon. They're going to be a DSM-6, and DSM-6 will correlate all this now with white matter tract and gray matters. So that is how psychology and psychiatrists have improved. So you can see all this, the abnormalities associated with negative cognition, arousal, and negativity, and what's actually happening in relation to the brain circuit dysfunction. We will hear from our clinical psychologist to be soon about negative valence and positive valence, what it means. Okay, so you see the whole criteria is here, DSM-5. So when we have PTSD, we have different forms of PTSD. You have the classic PTSD, and even according to DSM-5, you have dissociative identity disorder and PTSD dissociative subtype. So this requires a very smart psychologist, psychiatrist with certain tests to be able to group the person into which group. But what this paper, Nature by Fenster, has suggested is that you can define them according to the anatomy seen on fMRI or on tractography. So in patients with classic PTSD, they have increased amygdala in insular activation. It's always being activated. Remember, amygdala and insula in a normal human being is not always activated in an abnormal increased manner, because if your amygdala is and insula is constantly being activated, you will have problems. You will not be able to sleep. You'll always be thinking of something. You're always fearful, you know. So insula, and then in insula you have problem with sleeping, smelling, tasting, hearing, moving. So this will affect your cognitive, your motor, your sensory, your behavior. There will be a lot of parts of your brain affected. And in classic PTSD, your decrease of ventral medial prefrontal activation. So if you do, for example, a fMRI, you will see that the ball signal in this area is decreased. So the PTSD dissociative type, you see opposite is decreased amygdala and insular activity and increased BM, ventral medial prefrontal cortex activation. So those who do not come into this group or this group, according to the imaging, are put into this drawer, the dissociative identity disorder. You know, so it's like in between both. It's neither classic, it's neither dissociative subtype. So these are put, and this means that the treatment for 1, 2, and 3 are slightly different, both psychologically, psychiatrically, with drugs, or even with stimulation. Okay, so this is a story about the amygdala. So the amygdala is an organ found in your temporal lobe. Okay, in fact, in the last year's exam, we asked the student to put a pin into the amygdala to locate amygdala in the temporal lobe and tell us where the amygdala is. So amygdala is a small little structure, but the amygdala has got micro circuits. So just now we were talking about big circuits. So big circuit is like the circuit, the electrical supply that comes from, let's say, KL and supplies, for example, Johor Bahru. So there's this big cable, either underground or in the sea or in the river, flowing from Johor Bahru to KL, KL to Johor Bahru. Those are big circuits. But remember that they're also small circuits. They're called micro circuits. So there are big circuits called macro, M-A-C-R-O, macro. Macro is big. Small circuits, micro circuits. And you also have normal circuits. Okay? So micro circuits are implemented in field conditioning. So you have small little circuits in the amygdala, which different parts of nuclei. This is just for you to understand. You don't need to memorize this. If you want to, you can always read this paper. Okay. Some of the nucleus they cause excitation. Some of them give you an inhibition. This hypothetical story, you don't have to remember this. This is because they wanted to do some experiments, so they think that these circuits are hypothetical. Some of them have not been discovered yet. Some of them are just on paper. The scientists are thinking about it. So even a small structure like the amygdala has got its own internal circuit. So you have the town of Kota Baru. Kota Baru has got its own municipality. It's got its Majlis Pembandaran Kota Baru. And even in Kuala Lumpur, you have the city of Kuala Lumpur has got its own city council, city hall, with its own circuits there. And then you have the circuit in Putrajaya, the Prime Minister. The state of Selangor has got its own circuit. So the state of Selangor, the Chief Minister does not listen to the Prime Minister, etc., etc. So it's the same for the brain. You may have a problem where the amygdala's microcircuit, we assume this is the state of Selangor, is not listening to Putrajaya, Mahyudin Yassin. He's not listening because he has his own circuit. Selangor has got his own circuit. Selangor circuit is doing very well. So it's not interested to be involved in the larger circuit because the larger circuit in Putrajaya does not contribute anything to these micro circuits. So the study of circuits in post-traumatic stress disorder is ongoing. They have to, this dotted line is still experimental now. But it's important to know why, because if you know the amygdala microcircuit, I love to cause increased excitation in a soldier. Why? For certain nuclei, for certain circuits. Because I want to have a fearless soldier. If I'm just only interested in certain inhibitory circuits, I may find a soldier who is a coward. So I do not want the soldier to be a coward. I want him always to be in excitation mode for certain micro circuits. So even this is micro circuit, this is the amygdala. You see in this diagram, you have one circuit here, two circuit here, and some are running in circles because they have different nucleus. Some of them are straight line from one big nucleus to a smaller nucleus, Some of them are going long way, like driving from Shah Alam to Kajang or Kelang. Some are very short pathways. So these circuits, some of them are experimental so these circuits are important because when you can artificially stimulate and increase the pathway of the circuits to improve the PTSD of the subject, of the client. Okay, that's the end of the talk on post-traumatic stress disorder. I would like you to ask questions now. Any questions? Any
Prof?
questions? Just now I think yes. Go on.
Prof,
You want to
just now, Prof.
You want to tell me about valence?
Huh?
You
Oh,
want to tell me about normal valence? I think I asked someone to look for this. Negative valence and positive valence.
It's me, Prof.
Yes, can you tell me? What have
So
you
what
found out?
I found is the negative valence is responsible for response to adverse situations such as fear, and then the positive valence is responsible to respond to positive motivational situations such as reward.
So every normal human being has got negative valence and positive valence, no?
Yes. They must have to
Yes.
be balanced.
Yeah. So some people have got, if you look at DSM-5, this is under arousal and reactivity. When you have negative valence, you have no feeling of recklessness or self-destruction behavior. And then if you have positive valence, you will have more of this, okay? And if you want to be a good soldier, you do not want the soldier to be reckless or having self-destructive behavior. So you want the soldier more to have negative valence system than a positive valence system, no? So in some patients with post-traumatic stress disorder, they may have a different negative valence system and positive valence system. So with psychotherapy, behavior therapy, drugs, or even the stimulation, electrical stimulation or magnetic stimulation, to be able to change the negative valence and the positive valence system. So there's a lot of experiments going on now, especially in the West, especially in United States. DARPA, DARPA is we call it military neuroscience. So they're trying to get soldiers who are super soldiers, and they're trying to cure soldiers who came back from Afghanistan, from the US wars, so that at least all these problems can be controlled or reduced. They may not be able to cure the guy, but they are able to reduce the amount of abnormal positive valence or abnormal negative valence, social processes, arousal, and regulatory system. So depending on what the person has. Okay. Question?
Professor, is it possible that because we talk about the military in what has happened to all these refugee areas in Afghanistan or the other areas in the world, those have this kind of only have, if they have positive valence system for recklesser or self-destructive, is how they can be trained before they send to their places, how they can recognize before they send to their places.
Yeah. That's why to recognize them, number one, the cheapest cost effective is good old psychological tests. So there are a lot of clinical psychological tests for this. That's number one. Number two is sometimes they argue that the tests are not sensitive enough. There's always a sensitivity and specificity with the test. So with the test, if you do the MRI, the functional MRI, or the tractography, you're able to see all these changes, then you'll be able to catch the client or the subject or the patient earlier. And then you'll be able to monitor the subject objectively, because there's a bit of subjectivity with some clinical psychology tests, but with imaging, there is more objectivity than subjectivity at the current moment. But you need to use very expensive machines. 3 Tesla, they cost 21 million ringgit. The subject has to spend 1 hour to 2 hours in the machine. So it's not that cheap. It's not that easy.
I see. Okay, so that's why they mostly send it after the vaccination, probably.
Yeah, maybe, yes.
Thank
Okay. Any other questions?
Hello, Prof.
Yes.
Prof, I still cannot understand with DSM-5 and related with the RDOC domains.
What you don't understand?
I don't understand. For example, like this intrusive memory. So the negative valence system is lost, and the positive valence system is none. It means the negative valence and positive is
Go on.
don't have for that patient.
Yeah, but remember, everybody is different. Okay. So
Okay.
this is the R. If you look at DSM-4 and DSM-3,
Okay.
the RDOC domain was not so strong. If you look at the old diagnostic criteria book, you can Google this. So in DSM-5, they decided to break it up into domains. So instead of saying someone has got intrusion, okay, intrusion, what is under intrusion? Your patient got intrusive memory. Your patient got distressing dream. Your patient got dissociative reaction. Your patient got psychological distress. Your patient got marked psychological reaction. Okay? But the domain is different. I have intrusive memory, but my negative valence system is not lost. My positive valence system is none. You understand that? My social process is not lost. So every human being will have different RDOC domain. So not everybody, all human beings, let's say you have 55 people with intrusive memory, not all of them will have the same domain. Some of them may have lost, some may not have lost, but they are still under criteria B, intrusive memory under intrusion.
Oh, okay.
You understand that? They did this for epilepsy also.
Prof, so is it important for us to know negative valence system, positive, about RDOC domain for the client?
What are you? Are you a cognitive neuroscience or are you a clinical psychologist?
No, clinical, cognitive neuroscience.
Okay.
Cognitive neuroscience.
Yeah, okay. Cognitive neuroscience, because you know all this negative valence, positive valence, cognitive. To know whether this fellow got cognitive valence, positive, you have to do a barrage of psychological tests. So cognitive neuroscientists, not many cognitive neuroscientists, because cognitive neuroscientists use more technology than paper and pen tests. Psychologists use more paper and pen tests than imaging. So if you are a cognitive neuroscientist, this RCOD domain may not be, can be important, but if you want to learn about this is a lot of things you have to study lah. But for a clinical psychologist, this is very important.
Oh, okay. Now I understand.
You understand that? Because this ROC got nothing to do with imaging. See, there's no imaging here. This is all psychology tests.
Yeah,
1,
okay.
2, 3, 4, 5 ni arousal. This is all psychology tests.
Okay, I understand.
Patient
Thank you,
into
Prof.
which drawer? Okay, you understand that?
Yeah, okay. Thank you, Prof.
But if you are cognitive test, you cognitive neuroscientist, you may only know patient got intrusive memories. Then if you want to know about all these things, you may need either to subspecialize or you need help from the clinical psychologist to help you lah.
Okay, thank you, Prof.
Okay. Okay. Any other questions? There are 43 of you. I don't think all of you understand what's going on.
Professor, can you please explain a little bit more these inhibitory connections that you mentioned before?
You're talking about this lecture or the lecture before?
No, it's this lecture. You show it. You talk about here.
This one. Okay. Yeah, okay. So in our brain, let's forget about amygdala. You have gray matter, white matter, and within the gray matter is on the surface of the cortex, and then within the brain, you cut the brain like you cut a gardenia bread, you will see there's also gray matter in the very deep into the brain, even 6-7 centimeter deep. So Gray matter consists of neurons. Okay, so you can have a few million neurons, you can have a few thousand neurons. Okay, so all these neurons have names. So they have names labeled here, as you can see, this example. So some neurons talk to each other when they communicate with each other. They have to communicate each other via axons. So neurons talk to neurons. So neurons have axons. Axons will talk to another neuron, and then that neuron will have axon talk to another neuron. So the circuits can be like this type of circuit, like a roundabout. You know, when you're driving your car, you have a roundabout. So there is a traffic light at every roundabout. You can have a straight road like this. Okay, you can have a short straight road, and you can have a very long straight road. Some of the nuclei can be very big, and some of the nuclei can be very small. Okay. So now we come to the excitation and inhibition. So when neurons want to talk to each other, they have to have a discipline. If they don't have the discipline, if all the neurons are talking to each other and they are excited, then the person will be crazy. The person cannot. You have to have some neuron resting, some neuron not resting, some activated, some not activated. So those who are activated are excited. That's what we call excitatory. So these neurons are excited because of the neurotransmitter. For example, when you drink coffee, you may be exciting this neuron. So this neuron is excited. So the axon is also excited. So when it talks to the other neuron, which is maybe, because this is the brain, maybe 2 millimeters away from it, the excitatory impulse given from this neuron to the other neuron will make that neuron. For example, this neuron is at the area of mathematics, frontal lobe. So by drinking coffee, you stimulate this neuron. This neuron sends an excitatory impulse to the other neuron in the mathematic area of the frontal lobe. And suddenly you're able to, after drinking coffee, do very difficult mathematics. Without the coffee, you're not able to do the mathematics. And then inhibition. Okay, inhibition is like this neuron talks to this neuron continuously. As long as this neuron is excitatory, you will not be able to go to sleep. So you need to get neurons that give an inhibitory response to that neuron so that your sleep center will ask you to close your eyes and go to sleep. So for example, if I give Valium is a medication given by the doctors when people have difficulty in sleeping, for example. It's a very cheap drug. Yeah, more expensive drug than that. Valium will increase the inhibitory response to the neuron that is responsible for sleep. So this neuron will tell this neuron who is excited and wants to stay awake, he will give an inhibitory response. So another neurotransmitter will be used so that this neuron will slowly shut down, not close, but it will shut down to allow that human being to sleep. So that's why excitatory and inhibitory is going on every time, even when we are sleeping. Even when you're sleeping, there is inhibitory and excitatory going on at the same time. So when I'm talking, I need excitation for the neurons which are moving my mouth. Okay? And I need inhibition for the neurons that control my swallowing. Because if I swallow and I talk at the same time, I'm going to have problems because I just want to talk to you. I don't want to swallow. So that's why inhibition works together with excitation at the same time.
I understand. It's very logical. But one thing, when you said you talk about the volume, do we need the external action to activate inhibitory neurons and axons?
Yes. Yes,
so, So you mean, for example, if I cannot sleep, I have to take a medication, or this is not happening automatically, that inhibitory neurons coming in the picture when I start thinking that, oh, I need to sleep or something like that. Do I need external?
That depends on person to person. Some
Okay.
people sleep easily without any stimuli. Some people need stimuli to sleep.
Okay. I
So
understand.
every mind is created differently. That's the beauty of the brain. I may be using more excitatory than inhibitory to talk to you, but someone else may be using more inhibitory than excitatory to talk to you.
Yeah.
Nobody is the same.
Okay, I understand.
Okay. Any other questions?
Prof, does that mean that some sort of neurotransmitters involved in the inhibitory and the excitatory?
Of course, tons of neurotransmitter. That's the problem with pharmacy, with the pharmacists. Sorry, pharmacists. I know there's a pharmacist amongst you guys. When you want to look for a drug, you concentrate on just one neurotransmitter, one compound, whether it's original or synthetic. But you must remember this, while I'm talking to you now, there are at least 36 neurotransmitters working in my brain now for me to present to you this PowerPoint slide. And just thinking of one neurotransmitter to solve the problem and the medication associated with it is not what it should be. So lots of neurotransmitters, tons. If you Google neurotransmitter, you will see the number of neurotransmitter a human being has. It's a lot.
That's right.
Yeah.
That's right. That's supposed to mean they're supposed to work in balance. So any of this goes way out of its balance, that's when you have some other side effects coming in?
Yeah, they go way off balance when you have, that's when you get diseases. That's why you have stress. That's where you have anxiety. That is the balance, because some balance can be solved within seconds, microseconds. Some imbalance takes months or weeks or years to be solved. So the most important thing is prevention is better than cure. Prevent the imbalance. That's why normal human beings have to do certain things so that they don't have imbalance of their neurotransmitters.
Right. So educating people on this will actually cause prevention rather than any repercussions, right?
Agreed. Correct. And it's
Thank you,
different from person to person. Female, male, gender, culture, all different.
Thank you, Prof.
Thank you. Any other questions? No one. Everybody, there are 40, whatever of you, and all of you understand all the mumbo jumbo that I'm talking about. You okay, yeah? Okay, if you are surviving, this is the last part of today's lecture. Okay. This is important for both clinical psychologists and also neuroscientists. Okay. The brain network in social behavior, emotional response, and depression. So you will see that in your one, because you're all separated now in your own little rooms and houses. When you are able to come together in a class and everybody's sitting in the room, 42 of you, you will see that every single one of you will have different emotional response and different behaviors in the classroom. During the lecture is being given, after the lecture, how you study, how you have lunch together, So every type of 42 brains of clinical psychologists and cognitive neuroscientists will give different response. And why is so? Or you say, genetic, because, I was born this way, you were created that way, etc., etc. So, there was a review article in 2017 by Carl Friston lab in United Kingdom, and Carl Friston is also a very smart guy. Recently, Carl Friston was involved in looking at the curve, the COVID curve in United Kingdom. He's also an epidemiologist and statistician, so he's very good at brain network modeling and brain modeling to look at diseases. So what he did is he looked at the brain, and of course, when you do imaging, there will be a lot of areas light up, increased blood flow, in certain areas when you give them certain tasks. So what these scientists do is they use different modeling like functional connectivity analysis, dynamic causal modeling, and Granger causal modeling, which is a lot of formulas, a lot of advanced mathematics and physics and computer science to interpret certain behavior during the bold signal of the human being. So he looked at depression and he looked at other parts as well. So, and he looked at when you go at it, we are going to concentrate on depression first. Okay, so I'm talking about depression first because you understand depression, you understand the components. So, in clinical psychology, a lot of you guys can remember half of the class or more than half are clinical psychologists. So when they look at clinical psychologists, you guys diagnose clinical psychology by doing clinical tests, clinical psychology tests, complex tests, simple tests. None of the clinical psychologists I know in Malaysia uses MRI or tractography or whatever. But right now, looking at brain networks and circuits, okay, even if the guy is mute, he cannot even talk, but with the functional MRI, you're able to already, in a human being who is depressed, look at the different stages of depression. I think our clinical psychologists will agree with me that there are different stages of depression, from mild up to severe, and there are more eloquent scales for depression. Right now, with the MRI and knowing the circuits, the brain circuit in depression, you're able to divide it to at least, okay? Because this slide is 3 years old, okay? The paper, you're able to divide to anhedonia. So anhedonia ni nanti I want to get Melissa Lim, are you there? Melissa Lim? Yeah. I want you to read quickly what the definition of anhedonia is and tell me back in 5 minutes.
Okay.
Okay. And then Izmir, are you there?
Yep.
Okay, Izmir, I want you to look at the definition of rumination and get me back in 5 minutes. Okay? And then Auni Anwar, are you there?
Yes, doctor, I'm here.
Okay, look at the definition of dysphoria.
Okay.
And come back to me in 5 minutes. Okay. And then Tan Juin Ting, are you there?
Yes, Prof.
Tan Juin Ting?
Yes, Prof.
Look at the definition of disrupted cognitive control.
Okay, Prof.
And come back in 5 minutes for you to understand this slide. Okay, the circuit. Okay, so before
Professor,
while you're looking,
sorry, can I ask one question regarding this one? Because our first assignment, we talk about the female and the male brain. Is that can be different if we look at the female and the male brain? Is this can be so? Can do you have
different as well? Can be different as well. Absolutely. Okay, so while waiting for them, I'll skip that slide first. I just want to tell you that now we know when we know the circuits of the associated with depression. So now we can do many things. So, for example, antidepressants that we take, that we swallow. So, if we know that certain areas of the brain are involved, like the dorsal anterior cingulate cortex, okay, or the precuneus, or the angular gyrus, okay, or the posterior cingulate cortex. So the antidepressants can be given to treat these patients, okay. And for those others who think that the depression of the patient comes from dorsolateral prefrontal cortex, okay, the origin can give a transmagnetic stimulation, repetitive, R is repetitive, transmagnetic stimulation, or electric convulsive therapy. Do you know that some of the major depressive patients with suicidal ideas, they are given ECT, electroconvulsive therapy. This is planned to act at the level of the dorsolateral prefrontal cortex, so that when you do this, there will be, number one, inhibitory action or even excitatory action, depending where you want to aim for, in the circuits of the brain. And if this is the ventral anterior cingulate cortex, where DBS is deep brain stimulation. I make a hole here, I put electrode into VACC, and this patient who is depressive and wants to kill himself or herself becomes a very happy human being and is not depressed anymore, So right now, the modalities of treatment for depression are many. 1, 2, 3, 4. 3 which are non-invasive. 1 which is pharmacological, that means you're giving tablets or whatever. 2, you zap the brain, and this one you really operate the brain. You put an electrode into the nuclei, you stimulate the nuclei so that it gives a negative feedback to the hippocampus or amygdala, so that the patients improve in his depression. And this also depends on your what's happening here, whether you have this type or this type or this type. So when you know the circuits, you're able to decide what's best for the patient. Okay, now I just want to go back to our people just now. Have you found that? Have you found the story already?
Yes, Prof.
Who wants to start first?
Probably I can go first.
Go ahead.
So for anhedonia is the inability to feel pleasure, meaning you can't feel happiness. It's a core symptom for depression. And the symptoms of anhedonia include like social withdrawal, lack of relationship, negative feelings toward yourself, reduced emotional abilities, having difficulty adjusting to social situations, a loss of libido or lack of interest in physical intimacy as well.
Yeah. So in the brain circuit, anhedonia is caused by abnormalities of the prefrontal cortex, caudate nucleus, and nucleus accumbens, NA. Nucleus accumbens is a very small nucleus in the frontal lobe, deep inside the frontal lobe, and when any of these circuits are affected, you will have anhedonia. And you're able to look at the white matter tract using tractography, or you can even use fMRI, functional MRI, to see the blood flow in these areas to diagnose anhedonia without doing psychological tests. Okay, rumination is what?
Okay, so rumination usually you can it's like a repetitive thoughts that of a problem without any completion. So the thought about something that keep repeating and repeating and repeating. Usually the thought can be something quite negative, can be something about it being adequate or worthless, and this feeling of inadequacy will raise like anxiety, and this anxiety will interferes with solving the problem, then usually the depression will deepen.
Yeah. So you see the circuit here, you will see the medial prefrontal cortex, the posterior cingulate cortex, angular gyrus, precornea. So all these are involved. So you will see the circuit. It's a very interesting circuit, very long. You see the hedonia circuit is very short. It's like Kuala Lumpur to PJ. But this circuit is really long. This is like Johor Bahru to Kuantan, I think, maybe. Or maybe Johor Bahru to Penang. It's a very long circuit and a long white matter track, and involving connection between so many 1, 2, 3, 4 gray matter points. Okay, so when you look at this, there you are. You say, okay. So some are short and some are long. Okay, so that's rumination. So some people, some patients, they are depressive, but their level of anhedonia might be absent. He has more rumination than anhedonia, or some people have more dysphoria than rumination, for example. So dysphoria, who found out about dysphoria?
It's me, Prof. I'm Auni. So basically, dysphoria is when the dysphoria itself is excessive negative feeling. So it is connected to elevated connectivity of ventral limbic affective networks. So the one, basically the connectivity of the limbic system will create an excessive sadness feeling for people in depression.
So you see that the circuit for anhedonia is very simple, and the circuit for dysphoria is very complex. You see there are many areas: temporal lobe, frontal lobe. Okay, anhedonia is frontal lobe. Okay, rumination is frontal lobe going right to the back to parietal lobe. Okay, so you will see that different lobes are involved. Disrupted cognitive control is what?
Hi, Prof. So, cognitive control involves several processes, including evaluate like the objective of an action and determine the optimal choice in a situation. So, in the case of depression, those individuals have had disruption in terms of emotional regulation, and they also have selective attention towards negative experiences.
Yeah. Okay. So you see all the different abnormal network in depression, and you not necessarily even in depression when you are absolutely normal. Some of you don't like to socialize. You like to stay alone. Some people like sambal. Some people don't like sambal. So this can be also because the inputs in the circuits here are different. So this circuit also stays in people who are abnormal and also in people who are normal, but maybe the level of the brain circuit, the inhibition and excitation may be different from one person to another person. So that's why we use this knowledge to decide what's the best treatment. So when you look at this diagram, you see the electrical stimulation and the magnetic stimulation is given to people more with disruptive cognitive control. Because through the DLPFC, dorsolateral prefrontal cortex, you can communicate to so many areas, and you're able to treat it with ECT or RTMS. Whereas a DBS, which is a surgical procedure, it requires you maybe for dysphoria, okay, maybe anhedonia, these two ideas, where one can get treatment from the dorsal, the deep brain stimulation, and the rest is mainly antidepressant. It can be a combination of both as well. Okay? So people have done so many studies. So this is a fMRI study looking at the connectivity between right brain and left brain, front to back, back to front. Okay, so you can see that white matter tracks. Okay, the white matter tracks are written here in purple. So these are the white matter tracks. So you will see white matter tracks are present both on the right side and the left side. But what's more important now, this is an example to show you that some white matter tracks in some human beings can be very thick, and some in other human beings may be very thin. So the people with with thin white matter tract, that means the number of exons is decreased, may have more problems with depression. So if you can increase the thickness of these purple lines by stimulation or other modalities, you may be able to improve the connection between the different nuclei and area in the brain. Okay, so this is just one circuit I'm talking about, the dopaminergic system, self-reference, reward, and decision. So when you are depressed, or you have problems in interaction with society, you will have a weakness of the dopaminergic system. So you see the colors here. You have yellow, dopaminergic system, red, cognitive affective system, and then you have a mentalizing system and the premotor system. So this is the monkey. They did study monkey. Forget about the monkey. Just look at the human being, okay? And you can see that the thickness of the green area is more than the monkey. That's why humans are humans and monkeys are monkeys. Cognitive affective system is bigger in the human compared to the monkey, okay? So this is the anatomy of the cingulate. The cingulate cortex is very important in socializing, and it is all located in the frontal lobe. So if you have a problem with the frontal lobe and its areas, okay, like as shown here, you will have problems with socializing, having problems with decision making, self-reward, because if you have a very weak or bad self-reward system, you will have problems with socializing. So all these circuits here connecting different parts of the brain here is very important, and in certain human beings, their nuclei and the tracts may be smaller in size or smaller in volume, so they have more problems in socializing. So even in depression you do this. Even for socializing, you can also do stimulation in the 21st century in 2021. So by knowing the social circuits, you're able to do more and more, you know. So I think we can jump now. Okay, just to tell you that they have studied the circuits, and these circuits look at the emotion regulation, and then when you look at the emotion regulation, you will see that it's very, very different from one person to another. So these red little fellows here are nuclei or nodes, and the yellow are the white matter tracks. So you will see that the difference between person to person, especially when you grow older and older, the number of red dots and the number of yellow lines will decrease as you grow older and older and older. So as you hit 60 or 70 or 80, you will have difficulty in emotional regulation compared to when you were younger. Okay, I think okay. I just want to spend a little bit more time because I'm not sure whether Dr. Regu has talked to you about neurons, because in functional neuroanatomy, you must know that this fellow here called the neuron is the boss. And then this is a simplified diagram of a neuron, okay? So neurons make gray matter. Axon makes white matter. I think everybody knows that, kan? And some of them are shaped like this, you know? And some of the neurons do not even look like this diagram. Some of them have got 1, 2, 3, 4, 5 feet, you know, or 5 toes. Some of them got more than 5 toes. Some of them have very long axons, and some of them have got very short axons. Okay, neurons are, you know, the core of the brain. So you have nucleus, you have cell bodies, ribosomes, you know, you have the axon hillock and the dendrites. So the dendrites will talk to the axon terminals. So the neurons can be found not only in the surface of the brain, the cortical matter, but also found in gray matter within the depth of the brain. Okay, and then you have axonal transport. So the axonal transport will transport energy. Okay, so a bundle of these axons will create a fascicle, and the bundle of fascicle will give you a tractus. So if you read the functional neuroanatomy book, there are some are called fasciculus, some are called tractus. So that depends on the density and the size of the number of axons involved in the brain. Okay, so again, I show you that the neurons are different. You have multipolar neurons, bipolar neurons, pseudo-neuropolar neurons, and unipolar neurons. This diagram is important because it might come out as a multiple choice question, you know, about neurons. Blah, 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 A, B, something, C, something, D, something, E, something. So remember, you have multipolar neurons. Okay. So this is a classical multipolar neuron. One neuron has got many polarities. You have bipolar neurons. So the neuron is here. So one leg is here and one hand is here. Okay. Pseudo-unipolar. Okay. CNS terminals are here. Peripheral terminals are here. And then you have the unipolar, this is bipolar, where the neuron is here, but the dendrites are here. Okay? So multipolar, bipolar, pseudopolar, unipolar. There are no tripolar neurons. Either is one, two, or many. You do not have three polar neurons. That's just to remind you about the structure. Okay, and this is how they interact with each other. Neurons cannot survive without axons. Okay, and without astrocytes. These astrocytes are they take care of the neurons. They feed the neurons. You know, neurons are like the agong. It's like they are kings. So they don't do much for themselves. All these are their servants. The astrocytes keeping the neurons alive, and some of them can be short like this, some can be pretty long, the astrocytes. Okay, in cognitive neuroscience and in clinical psychology, most of us do not talk very much about astrocytes. We talk mainly about neurons because neurons are responsible for mind, thinking, etc. But if you are going to be a neuroscientist, you may also look at astrocytes because diseases of the astrocytes can also cause problems or diseases of the neurons. Okay, so this is like the axon. So some axons, which is the peripheral nerve. So for example, if you put your hand in hot water, you can feel the hot water. You can take your hand out of the hot water because you have an axon, and this is a myelinated axon. That means that it has a skin, like an onion skin, you know, you see here. So the advantage of having an onion skin is that the transmission from the neuron via the axon to another neuron is quick, very fast, you know, but not as fast as unmyelinated neurons, such as free nerve endings, where this onion thing is absent. So sometimes some of you feel the response late. For example, if you put your hand in cold water, compared you put your hand in hot water, your movement of the hand coming out of the hot water will be faster because of the myelinated axons, compared to cold water, which will take time because of the different receptors. There are other cells as well called oligodendrocytes. So I just want to tell you that neuron is not the only cell in the brain. You have oligodendrocytes, you have astrocytes, you have Schwann cells. So they are very important for the transport of salt, chloride, ions from outside of the neurons into the neurons. So these are very important. So if any of these transport doors are destroyed by disease, you will also have problems. Cognitively, you will have problems with behavior, of course. If you have, this has got something to do with sensation, you may have loss of feeling, If this is supposed to be your nerve cell for smelling, you will have loss of smell. And this is the nerve cell for listening, you may have problems in listening or decrease in listening. So these are on the wall of the neurons, and there are different ways of where the molecules transport and get into the neuron. So this gives energy to the neuron to move. Okay? So one neuron and another neuron, they talk to each other like this. So you have a junction there. This is like the bridge between Singapore and Malaysia. This is Johor Bahru, this is Singapore. So you have a bridge. Okay. So there are different bridges. One is the bridge for, let's say, humans to walk across. And there's another bridge for cars to walk across. So for the connexons, these are very fast impulses. These are electrical impulses. And the gap junctions, these are slow impulses. So if you put your hand in hot water, and your hand comes out of the hot water very fast, is because the impulses is traveling through the connexon. This is the electrical synapse. And if you put your hand in cold water and it takes you about maybe 20 minutes, then you feel that your hands are numb and you want to take the hand out of the cold water, is because the impulse of cold is going through the gap junction, and this is a bit slow. Okay, so God has created us to have two of them at the same time in every interaction between a neuron and the other neuron. Okay, and so the other one is the chemical. So you have the electrical part, and this is the chemical part. So they are neurotransmitters. So this is how the neurotransmitters work. Okay, there are some neurotransmitters produced by the neurons, and there are some neurotransmitters that are produced from outside the neurons. And you can see how one neuron talk to the other neuron. You see the axon interacts with the dendrite, and then you have them not interacting like this, but the axon interact with the cell body, and some they do it this way, exosomic, so body to body, body to axon, etc. So there are many shapes and sizes of these neurons. Okay, so I think I'll stop here. This one is more for memory and all that. Okay, any questions you want to ask? Depression is a very common exam question. So I suggest you study a lot about depression, because short essay questions, multiple choice questions on depression, all your exam questions already been prepared, has been vetted, ready to go. So I hope you will be able to understand the mechanism of social interaction, emotion, and depression. Any questions? No questions? Wow. Either you're totally confused or you understand everything. All these slides has already been uploaded to e-learning. Any questions out there? You're very quiet. Can you hear me?
Yes, Prof. Can hear.
Yes, can, Prof.
Yeah, so no questions. Totally
I have a
confused.
question. Yeah, cool. So you mentioned in the session that you have not seen any clinical psychologists using fMRI and all
Not
this
in
technology.
not in Malaysia.
Not in Malaysia. So
Singapore, yes. Australia, yes. Developed countries, yes.
So as we are going for master clinical psychologist, do you think we can do this, or this is something that we need to go further as any PhD?
This is at the level of clinical neuropsychology doctorate level. So the understanding of imaging alone doesn't come. You have to understand about clinical examination. A good clinical neuropsychologist knows how to examine a patient like a neurologist does.
So does it mean we need to go for a specialization?
Yeah, the doctorate lah. Kan you have doctorate D-Psych. D-Psych clinical psychology, D-Psych neuropsychology. All these things will be elaborated in very, very more detail in D-Psych neuropsychology.
Okay, thank you, Prof.
Okay. Well, question. That's future. This one. Another structure that also important for emotion is the corpus callosum that I show here. So some people have got different corpus callosum. I think you've been writing about the female brain and the male brain and the difference in the corpus callosum, the thickness, the length. So this is just example about corpus callosum. But this one is a mixture of human data and monkey data. When you read a book, this is a nice book, Hans J. ten Donkelar. They talk about the brain circuit and disorder. I don't know whether you have an e-copy of this book, but for those who are really crazy and really want to read about this, you're most welcome to read about the brain circuits according to ten Donkelar.
Professor, I have one question.
Yes.
Capsular callosum is when we compare differences between female and the male brain, we said that the brain is larger than female brain is larger than male brain. Is that can affect, because I haven't seen any pictures about the depression with differences between female and the male brain. Do you have any picture that you can share with us?
You're talking about picture about what?
Because you said to us that depression different between male and the male brain.
Yes.
And now we're seeing also capsular callosum that is the larger for female brain than the male brain, right?
Agree.
So how can affect the depression, and do you have any picture that you can share with us?
Okay, that requires neuroimaging. I've not given because today's topic is very general, not differentiating male and female brain. But if you want to see MRI pictures of female brain and male brain with depression, you can Google it. I can put it up on the WebEx. Oh, sorry, on the WhatsApp.
Yes. Yes, please.
No problem. I do not know what you want to do this. You want to show it to your husband or show it to your son or daughter, or you put it on the t-shirt,
I'm very curious because is actually the topic that I would like to deeply choosing in my for studies. But another question also you said that difficult emotional regulations after 60 years old. Can you a little bit explain what you mean difficult emotional regulations for those that are after 60?
Okay, so when you talk about emotional regulation, let me go and show you an example. Okay, so let's go, just keep to slide look at this slide and look at C. Okay, so in C, you will see these orange lines here are the communication with the different Brodmann areas. Okay, for a language, but let's forget about language. Just say that this is for cognition. Okay? So as we grow older, the lines become thinner. That means to say the size of the axons decrease in size. The areas, the number 8, 46, 10, 45 become smaller because of the size of the neuron decreases in size. So example, if you have 10 million neurons in area number 8, at the age of 18 is big, but at the age of 60, the volume, the surface area of area number 8 has decreased in size. So this happens especially for memory. It happens from the age of 45 in males and slightly older in females. Females, the decrease in the surface area and the thickness of the axons in females, they are protected because you have hormones, estrogen and progesterone. So when you reach menopause, that is when all these little surface areas start becoming smaller and smaller. In males, they are not so dependent on estrogen and progesterone.
And this 45, 46, was it the basal and ganglia area that is that we talk about?
No, this is different area. Hippocampus,
Hippocampus.
amygdala, frontal lobe. So many areas.
Okay. I see. Okay, I understand.
So different people have got different rates of atrophy. I mean, atrophy means becoming smaller, shrinkage of the brain. That's why from the age of 40, both male and female should start stimulating their brains, like exercising, so that the areas do not decrease in size.
Okay.
All the studies have been proven with MRI. Nothing new.
Okay.
But most of the studies were done on Caucasian brains. There are very few studies done on Asian brains.
Really? Wow.
Yes. Because only the developed countries have money to do all these studies. So even from a country like Japan, which is a rich country, the number of studies on the Japanese brain and tractography and surface area is not much, very little. Only from China now we're starting to see a lot of studies coming up, but those are Chinese brains.
I see. Okay. Thank you for the answer.
Thank you. Any other questions?
Prof, is there any tips from you besides exercising? How to keep these brains? Is there any tips from your side on how to reduce the brain degeneration in old age besides exercise?
Okay.
Is there any specific mental exercise?
Okay.
Such as?
Some people like you, or maybe if you're religious, prayer, meditation, even it's quiet, can increase the size of your surface area of your neurons and improve your axonal thickness. Tai Chi, your seniors are doing experiment on Tai Chi, on yoga, Some of them are using music. Some of them are just using sounds to increase certain areas. Remember, it's just like a road. When you travel from Johor Bahru to Penang, you can take the main road or you can take the side road. So, by stimulating, for example, area 37, if 37 is for auditory cortex, music, through this area 37, you can stimulate 39, 8, 46, 10 indirectly. So there are direct methods and indirect methods to stimulate the brain. Every culture, every neuroscientist has published a paper from music to exercise to food to sleep to able to stimulate the brain. So different people have different response to different stimuli, unfortunately. So we have to find out later that, because that's a big study, a giant study that needs thousands of human beings to be able to decide what kind of phenotype of human behavior requires this type of stimulation. That has not been done yet.
Okay. Thank you so much, Prof.
Professor, I would like to share with you and my friends in the class that motivation, I think, is the biggest, for me at least, to develop those areas. I think is okay, music, but for I remember many things I can forget, but certain things, when you have a big motivation, you remember much better than the other things that you may be not interested at all.
Yes, I mean, different human beings, because we have different stimuli, different cultural background. We were all born and exposed to different environmental factors. So whatever that you need to stimulate C directly or indirectly will be different from one human to another human.
Yeah.
Okay, any other questions?
Prof, I have a question
Yes. Mm-hmm.
about the junction gap proteins.
Okay.
What do they actually do? Because we only learn more about the chemical mechanism. So what about the electrical? Does it also produce EPSP and IPSP, or
Wow. Are you cognitive neuroscience or psychology?
cognitive neuroscience?
That's why you're asking that question. Okay, let me see. Where is the slide just now? Yeah. Okay. So the gap junction, okay, is a junction which is between the pre and postsynaptic part of the neuron. Okay. So it's like a little, I don't know what do you want to call it, Straits of Malacca, or river between Singapore and Malaysia. Okay. And the connexons, okay, are made of proteins. Gap junctions are also made out of proteins. And there are many gap junctions for different work. You see this diagram that, So, you have different functions. You have something that is used for simple diffusion. Some of them are mediated diffusion. Some are active transport. So different gap junctions have got different proteins, and each protein determine what is happening at that level. So there is a whole study on proteomics, I mean the protein type of gap junction, and there are also diseases of these proteins. In traumatic brain injury, the gap junction is totally destroyed. Even the connexon is destroyed. So there is no gap junction at all. And just having two neurons, neuron 1 and neuron 2, which is normal, but a gap junction that is destroyed by trauma, diseases, etc., will not allow transmission of action potential from neuron 1 to neuron 2. Therefore, that part of the pathway doesn't work. So the proteins are also involved. But these proteins have already been formed since you were a baby. So eating all the KFC, all the steak, all your burgers will not replace a destroyed gap junction channel and its protein. Do you understand or confused?
Yeah, a bit confused too.
What are you confused about?
I just want to know what is the function of it? What does it do?
Okay, so without the gap junction, you will have nothing going through. Gap junction allows things to go through here. So these are electrical discharges. It's called, you have, like I told you, this is a fast and this is a slow. This is chemical synapse. This is electrical synapse. So electrical synapse have got proteins, they shape like this, that allows for the action potential to move very fast through this bridge to the opposite side. So any disease, one common area for gap junction is your heart. Your heart never stops. It cannot be slowed down artificially it can, but even if you want to think about slowing it down, you can't, because the heart beats as long as you live. So your heart has got these neurons that move from your SA to AV node, if you remember your biology, and they are using gap junctions only. In your heart, you don't have chemical synapse. You only have electrical synapse. So where else can you find gap junctions? In your brain, which require fast movement. For example, where do you want fast movement to occur? Vision. I am looking at the PowerPoint. The color comes into my eyes and goes to my occipital lobe. So it requires gap junction. If I'm using chemical synapse for vision, I see the object. By the time my brain recognizes what the object is, a little boy, I would have run over the boy because I'm using chemical synapse. That's why God created that the heart and parts of the occipital lobe uses gap junction channel because it's fast. This one, the chemical synapse, you have to swim over, That is like a channel. You have to swim. The synaptic vesicle has to swim over the channel to go to the postsynaptic part of the neuron. Whereas here, it's like a fast-track bridge. The impulses move from presynaptic to postsynaptic very fast.
Professor, this is those protein drinks that many sports people are using it. Is that can affect this gap junction? Can be dangerous for the many sports people?
Okay, you are born with a fixed number of gap junctions and chemical and I call it electrical and chemical synapse. So this is chemical synapse, this is electrical synapse. You're already born as a baby. So drinking proteins or whatever that you want to do will not improve or increase the number or quality of the gap junction.
Fantastic. Great to know. Thank you.
So all this milk advertisement and for babies and for sports people, it will not affect the gap junction. What it will affect other things like neurotransmitters. Those can be affected by your food and drinks, but gap junctions do not change with food, And when this gap junction is destroyed, like your heart, you use an electrode to replace this gap junction, which is called a pacemaker.
Yeah.
So in deep brain stimulation, we put a electrode into a nuclei to stimulate the brain. What we are doing is we are replacing the gap junction that is ineffective. It may be there, but it's not doing its work.
I see. Thank you. Thank you very much for that information.
So Hanisa, faham tak? Or still confused?
Faham. Thank you.
Okay. So any other questions? If no questions, so from my 3 PowerPoint slides, I want you to focus on depression because it's so common in Malaysia now, and the neuroanatomy and the brain circuits of depression. Okay, and then what's also important is you should know about the frontal lobe, all the prefrontal cortex, the sulcus and gyrus, and the circuits associated with it. Okay. to make it very exam oriented.
Okay,
Okay,
hi, Prof.
thank you
I
very
have one
much.
question. Sorry. Just as you
Okay.
mentioned depression. So when it comes to medication therapy for depression, of course, it's not as straightforward, say, as compared to hypertension treatment. And very often we will see patients who are being treated with antidepressants. They respond, experience the medications very differently, although they are pretty much being treated with a similar class of medication, say SSRI, for example, and not considering like non-compliance or misdiagnosis or external factors. Just want to get or hear your opinion as to why will patients experience or respond to medications differently.
Yeah, the problem with the diagnosis of the depression is done in the old way, the old school. So the problem with depression is number one, the gray matter and the white matter associated with the depression. Number two is the white matter connectivity or the brain circuit associated with different sub complaints or the patient has with that depression. Number four is the receptors. The receptors that we are working on when we have depression, it is not the cause is not from one or two or three receptors. Remember, if you look at wiki, I don't know whether someone has opened wiki and look how many receptors we have. We have so many types of receptors, and if we look at the receptors that cause depression, there are more than 20 receptors that are associated with depression. Most of them there is no medication for. The medication does not exist. So whatever medication that was given for the current cohort of people with depression in 2021, it is with a simplified ideology that depression is caused by serotonin or non-serotonin or whatever. Whereas depression is more complex than we think. And the drug pharmas do not want to work together. Company A is producing compound A, B, C is completing the compound. They did not want to combine their tablets or their chemical compounds. So, and some patients, if we know what's actually going on at the moment, what we call it molecular MRI is coming soon. Molecular MRI is like a PET scan, that will be in the next 10 years, where people will use PET or PET-like imaging to diagnose psychiatric diseases and looking at the receptors involved. Receptors and neurotransmitters. First neurotransmitter, but neurotransmitter is easy to detect in the brain compared to the receptor. Then will the pharmacy treatment of depression improve? At the moment, all the drugs for depression do not have 100% effectiveness. Some of them are only running at 50%. You ask the psychiatrists and psychologists, they keep changing the drugs because there is a tolerance to the drug that's being used. So in the end, if some patients go to major depression, they will end up with ECT and other modalities for treatment. Some patients are on 3 different antidepressant drugs and none of them are working maximum. So truthfully, sadly, until today, it's still our fault. We do not know how to treat depression, not only depression, psychiatric illness, epilepsy, forget about that, brain tumor. Well, it will take us another, I think, 50 to 100 years before we sort this out. So that's the problem with science. I hope I have answered your question.
Yes, I truly believe that the current pharmacotherapy treatments that are available are rather simplistic to treat psychiatric disorders. Yeah, but thank you for your opinion.
Yeah. Okay, I think that's enough. If you don't have any more questions, we will stop now. Any other queries? No? Okay, thank you very much.
Thank you so much, Prof.
On the 1st of December, I will email to Shamimi and your group assignment 2. Assignment 2 is full of white matter tracks. Unfortunately, we cannot play with the brain yet. Hopefully, when things get better, maybe a few weeks before the exam, if we can, even playing the brain might mean me playing the brain, but you guys cannot touch the brain. So we'll see what happens during this COVID pandemic. Okay, thank you. Bye-bye.
Thank you, Professor.
Thank you, Prof.
Thank you so much, Prof.
Thank you, Prof.
Bye.
Assalamualaikum. Have a good weekend.
Um,